Okay. Good evening, everyone. Welcome to the Journal Club. Today's topic is an interesting topic and a hot topic, which is on GLP-1 receptor agonist versus surgery for obesity treatment. So, Dr. Sameer will take us through the study.
Sir, I'll start, sir.
Yeah,
Yeah.
please.
Good evening, everyone. I'll be presenting this month's journal club. My journal study is on the journal club is on obesity treatment with bariatric surgery versus GLP-1 receptor agonist, which is a retrospective cohort study. The study was a retrospective, observational, non-randomized study with a intention to evaluate the real-world clinical and economic outcomes of metabolic surgery versus GLP-1 agonist in class 2 and class 3 obesity. The chief investigator of this study is Dr. Tyson S. Barrett, who is a manager of research analytics and at Highmark Health. He has joined since 2022 June. He leads a team of informatics, biostatistician, and clinical population. And his main work is to enhance, his study is on to enhance health service research. The study was published in 17 September 2025 in JAMA Surgery of volume 160, number 11. As you know, JAMA Surgery has the highest impact factor of 15.9 and a site score of 20.8. The data source of this study was mainly electronic health records and insurance claims. So before we dive into the study, I will the main thing about the study is it is linked to two major data sets. That is Highmark Insurance Claims Database, which is a insurance claim database which captures diagnosis, procedures, the total cost, and the health service utilization of the patients, both indoor, outdoor, and the emergency visits. And the second database is the Allegheny Health database, which is a non-profit organization of 14 hospital system in Pennsylvania. And for this study, they have provided the patient statistics, demographics, and comorbidities. So there are two cohorts, subsets of cohort in this study, which is a economical cohort and a clinical cohort, which we will be seeing later. The clinical question of what the study was the investigator wanted to evaluate is the comparison between metabolic and bariatric surgery and the GLP-1 agonist with the expected outcome to evaluate the superiority between both in terms of weight loss, the costs, and the healthcare utilization. So, introducing as we know, obesity is a chronic, progressive, relapsing disease characterized by excess adiposity that impairs health, and it is a rapidly growing proportion. It affects rapidly growing proportion of the adult, as we know, both in the West and globally. It is not merely a condition of weight excess, but it is a metabolic disorder associated with systemic inflammation, hormonal dysregulation, multi-system involvement. Over the past decade, the prevalence has rapidly raised with the despite the expanding therapeutic options. That's the reason which it underscores this shows that we don't the complexity and the of pathophysiology and management of obesity. The burden of obesity is substantial both clinically and socially. Individuals living with obesity face increased risks of future risk of type 2 diabetes mellitus, hypertension, dyslipidemia, cardiovascular disease, obstructive sleep apnea, fatty liver disease, osteoarthritis, infertility, and also increased risk of certain cancers. Beyond the physical illness, obesity also contributes to reduced functional capacity, psychosocial distress, and a impaired quality of life. At a population level, it is the most leading cause of preventable morbidity and mortality, and it reduces life expectancy of patients, straining healthcare system. Obesity has both direct and indirect healthcare cost. The direct cost, as we know, which will include hospitalization, outpatient visits, diagnostic testing, medication use, and also the one which will be seeing, which is the long-term management of obesity-related comorbidities. Indirect cost can be due to disability, the population being absent from work, and also a sizable proportion in the West has they spend a sizable portion of the healthcare to obesity, with exposures progressively rising with increased BMI and worsening of metabolic disease. The economic impact mostly is a long-term thing, and because the comorbidities require lifelong treatment and surveillance, pharmacy expenditure have risen sharply, particularly with the use of the new hot trending anti-obesity and anti-diabetic medication. Management spans through spectrum of interventions. Initially, lifestyle modification, including dietary counseling, behavioral therapy, and exercise, and then pharmacotherapy, which targets appetite regulation, insulin sensitivity, metabolic pathways, and then there is endoscopic intervention, and finally metabolic and bariatric surgery such as sleeve gastrectomy or Roux-en-Y gastric bypass. Among these, metabolic bariatric surgery is considered the most effective and durable modality, with robust evidence supporting significant weight loss, improvement of metabolic parameters, reduction in long-term mortality. But despite of this all clinical superiority, the utilization of bariatric surgery remains low. What are the problems of the both metabolic surgery and GLP-1 medication? The first one is durability, which is weight regain, is very common after discontinuation of GLP-1 medication. The current evidence suggests that lifelong therapy may be required to maintain the weight loss, contrasting the durable metabolic improvements which are seen after bariatric surgery. And there is a high ongoing cost of GLP-1 receptor agonist, and they have a monthly expense which accumulate indefinitely, and this creates a long-term financial burden on the health system and insurance. The real world effectiveness is actually variable, because the adherence to the GLP-1 agonist is variable. There is mostly medication discontinuance, insurance coverage gaps, and also difference in drug potency across the agents. Side effects such as mostly which are gastrointestinal adverse effects such as nausea, vomiting, diarrhea, constipation can lead to treatment interruption, and long-term safety is still yet to be established. And finally, we come to the underutilization of bariatric surgery. Despite evidence showing established superiority, bariatric surgery remains underused, mostly due to patient hesitation, misconception about the surgical risk, which is mostly leaks, and a limited referral pathway, insurance barriers, and always a preference to non-invasive pharmacological approach. Uh, the mostly the two bariatric surgeries which this study and also which is globally used is the first is the gold standard, which is RYGB, Roux-en-Y gastric bypass, which is a malabsorptive restrictive metabolic operation, and it is considered the gold standard for bariatric treatment since decades of outcome with evidence of decades of outcome of data. A small gastric pouch of about 30 ml is created by stapling the upper stomach, and then the small intestine is divided. There will be the roux limb, which is the which carries the food from the pouch, and then there will be biliopancreatic limb, which carries biles and enzymes. And these limbs are then connected in a Y-shaped fashion, which allows the food to move slowly, and digestive juices to mix. The Because it is restrictive, the small pouch limits the intake of food, and then mild absorption is there. And there is shortened common channel which reduces calorie and nutrient absorption. And the most dramatic increase in GLP-1 receptors, incretins, and reduction in ghrelin secretion. Then the second one is the gastric bypass, which is sleeve gastrectomy, which is currently the most commonly performed bariatric surgery worldwide. It is a restrictive metabolic procedure that permanently removes approximately 70 to 80% of the stomach, and it converts the stomach to a narrow tubular sleeve of a capacity of around 60 to 120 ml. So this table shows us the main difference between sleeve gastrectomy and Roux en bypass. Roux en bypass is more complex technically, and the reversibility, sleeve gastrectomy is irreversible. This bypass is partially reversible, but it is very difficult. And comorbidity remission, type 2 diabetes mellitus, very high remission in Roux-en-Y gastric bypass is seen. Almost estimated weight loss is almost 65 to 80% in Roux-en-Y gastric bypass.
Samir, just go back to the.
Sir,
See you said typical weight loss um, is 55 to 70% in sleeve and 65 to 80. If you look at this paper across, it is about 28%. So how do you account for this difference?
uh, sorry, sir.
The if you look at the if you go through the paper, it says the weight loss
Yes, sir.
across all the metabolic surgery. This one is about 28%
Yes,
compared to
sir.
about 8 to 10% with the uh, the drugs, that is the um,
GLP-1.
GLP-1
Yes, sir.
is one receptor and agonist.
Yes, sir.
So, but
Sir,
here you say expected weight loss is 55 to
sir,
70.
sir, expected, no, sir, like excess weight loss, sir.
Excess weight loss. Okay.
Yes, sir, excess weight loss.
So excess weight loss means if
Like
you
the,
have
yes,
beyond their expected BMI for
yes, sir,
their
yes, sir.
height.
Yes, sir. The excess of the weight which is lost. Yes, sir.
Okay, right.
Then we dive into the approved drugs. The For now, which the drugs which are FDA approved are tirzepatide, semaglutide, and which are the brand names of Monjaro, and then we have semaglutide, which is Ozempic. The main mechanism of GLP-1 receptor agonist is that they bound to the GLP-1 receptors in the arcuate nucleus of hypothalamus, and which is a key appetite regulating center. This binds the stimulants which are through the POMC neurons, which promote satiety, while simultaneously they inhibit, which is the NPY and AGRP neurons, which normally drive the hunger and food seeking habits of the patients. Both the combined effects shift the hypothalamic signaling towards fullness rather than hunger, and then it reduces the appetite. There will be low energy intake, fewer food cravings, and increased satiety. Through this central neuroendocrine modulation, GLP-1 receptor agonist effectively prevent overeating and contribute to sustained weight loss.
No,
The
but yeah.
sir,
But how do you explain
sir,
the almost normalization of um, this one blood sugars in patients from day one? It is not the weight loss that causes the uh, decrease in the sugars, but from day one there is better glycemic control. How do you explain that? Not just by appetite, because appetite is only a small part of it.
this GLP-1 receptor agonist will also increase the insulin sensitivity,
Correct. That is
and
also
they will decrease the hepatic glucose production. Also, the lipid accumulation is also lesser. So,
that
There
uh,
is
will be gastric stasis also. The food will not
Yes,
go
sir.
down faster.
Yes, decreased the gastric emptying will be less.
I think apart from it, they will increase the insulin production from the islet cells of Langerhans, reduce the peripheral resistance to insulin. I think that is also very important. So because of those things, there will
Sir,
be initial reduction almost from day one after bariatric surgery, or starting to take the GLP-1 agonist. Actually, GLP-1 receptor agonist came in because of the metabolic effects of the bariatric surgery. They realized as soon as surgery is done, GLP-1 agonist levels go up. So then they
yes.
started working on that to uh, produce drugs which will work on the GLP-1 receptors. Okay, carry on.
Yes. And the second set of drugs which we'll be talking about is glucose-dependent insulinotropic polypeptide receptor. These GIP agonists aid in weight loss, and they enhance the GLP-1 agonist therapy through complementary central and peripheral mechanisms. Uh, the it was historically viewed that it mainly acts on incretin, but later on they found that it synergizes with GLP-1 signaling in brain, particularly with hypothalamus activating the appetite circuits, dampening food intake and improving energy balance. This also reduces nausea pathways and improves tolerability of the GLP-1 therapy. Peripherally, the GIP enhances glucose-dependent insulin secretion. It improves insulin sensitivity, and favorably, it alters the adipose tissue metabolism. And in patients who have who have taken the dual therapy, it amplifies weight loss, improves glycemic control, and allows a greater efficacy at lower GLP-1 related side effects, resulting in more sustained reduction in appetite and like final overall weight loss. So these are the drugs which this study has used. There are because the study was from 2000, the 2018 to 2023, the newer drugs which are currently used and have a higher efficacy were also used, and they don't have a separate subset. Like they haven't done an analysis for a separate subset of this GLP-1 agonist. According to the current systematic review and meta-analysis, it is found that tirzepatide produces significantly greater weight loss than the semaglutide, which is Ozempic, with a pooled difference of around 4.23 kgs. And also there are trials which such as the Surpass 2 trial, which also has shown greater weight loss for patients who have taken tirzepatide than the semaglutide in patients with type 2 diabetes mellitus. Um, yeah, and this is the typical diabetic dose of semaglutide or Ozempic, which is about 1.1 to 2 mg weekly dose, and the weight loss dose is 2.4 mg weekly, slightly higher than the diabetic dose. As of for the tirzepatide, which is about 2.5 to 15 mg weekly, it is the same range, but higher doses are generally used for maximal weight loss. Coming to the methodology, as we have discussed earlier, it is a retrospective study, and patients with diagnosis of class 2 diabetes, class 2 obesity, BMI more than 35, and class 3, which is BMI more than 40, were included. Group 1 was the metabolic bariatric surgery, sleeve gastrectomy, or gastric bypass. Group 2 was GLP-1 receptor agonist, which were either for obesity or diabetic management, with a sample size of 30,458 patients, and data sources which are Highmark Health Insurance and Allegheny Health Network electronic health records. The study period was from 2018 to 2023, with a follow-up of mean of 33 months, and primary endpoints with economic endpoints to evaluate the monthly and total healthcare cost over 2 years, both medical and pharmacy, and clinically the total weight loss and sustained weight loss, that is more than 5% weight loss and more than 10% weight loss. And secondary endpoints were a number of inpatient stay, like outpatient visits, emergency department visits, and reduction in obesity related comorbidities. So adults with diagnosis of class 2 obesity and class 3 were included, continuously enrolled in high mark insurance of more than 6 months before treatment, which was baseline, and more than 1 year after treatment, and received either metabolic bariatric surgery or GLP-1 receptor therapy were included. Both, if they had used both metabolic bariatric surgery and the drugs, they were excluded. Any missing diagnosis in claims and insufficient enrollment data, which is less than 1 year month of follow-up, were excluded. Critique.
Yes, Likith. We'll start with Likith. Likith, you're there?
Yes, there, sir.
He's not answering.
Yeah, that's
Sir,
what
he's
sir
on
is
call, sir,
on.
probably some.
Okay. Inas.
Yes, sir. Firstly, it is a relevant topic and it is and also a recent study. It is published in a journal which has a good impact factor, sir. So all of these come under pros. And the sample size, like the cohort size, is also quite large, which is a pro, sir. And the inclusion and exclusion criteria was also well defined, sir. So all of these are pros for the study. And in terms of cons, sir, like they used these they said that they've used these data records, like the health records which have been used. So can they cause it can cause selection bias, sir? Like that was one point, sir. And the other thing was like
No,
in
no.
terms of
What do you mean by selection bias? How does it cause selection bias?
uh, sir, like in terms of because you are not uh, wait, it is only available in a subset of patients, sir. Like as we go ahead, it is shown like only 1,500 of those patients are chosen, sir. So weight data is available
So,
only in a subset, sir. So can
no,
that
that is what. No. But you are partially right. But the whatever is available, they have taken only that much. No, 1,500 patients, it was available and it was taken. So
yes,
they are
sir.
not in those 1,500. If it was not there, then there would have been a problem.
Okay, okay, sir. Yes, sir. Like I thought, sir, like that I was not sure, sir, about that point, like if that could induce selection bias, sir.
No, first of all, it is a retrospective study.
Yes,
So
sir.
there will always be a kind of like your protocol. You won't have the pre-decided protocol. You have done your protocol and data for that. So there will be some issues always with the retrospective study. That is a negative.
Okay, okay,
Sir,
sir.
Ravi Shankar sir?
I think to some extent, as you said yourself, there could be potentially bias because out of some 177,000 patients, I think initially 190,000 odd patients, finally they have narrowed it down to 30,000 because some of them the data are not available and things like that. So if all of those people who they could have done, then maybe the difference between bariatric surgery and the GLP-1 agonist would have been far larger. So there will be an element of selection bias.
Hello?
Hello?
Sir.
Did you hear me?
Illa, it got cut.
I think basically, if you look at it, if you look at the flow chart, out of 190 to 1,92,000 or odd patients, they have systematically reduced it down to 30,000 in the end. So there is a huge cohort of patients who have actually been excluded for lack of data and a lot of other exclusions, which if you would have taken into consideration, if they all of them were available for analysis, maybe the difference between metabolic surgery and GLP-1 agonist would have been far larger, and it is not in the interest of the pharmaceutical companies. So maybe there is an element of bias.
But because can we call that a selection bias? Because it's a retrospective study, the data genuinely might not be there. So that's what. So we cannot like 100% say it is biased, but there will always be a commercial element because they are not able to show a great difference between this thing. So as you said, it might be true, but based on the whatever they've only taken 1,500 patients. In that 1,500 patients, they have shown the data. So, but since large cohort is missing, yes, I agree. There can be a bias. But whatever if they'd shown some bias in those 1,500 patients, then we could have categorically said there is a selection bias, Anta. So because it's a retrospective study, that itself is a negative thing. So they might generally be, and they've collected data from the insurance and all those things. So probably they might not have all the data in those patients. If they had taken it only from the registry, then probably they might have had.
Sir, one more thing, sir. In the study, they have told that the surgical cohort, they optimized them for a period of 6 months, and then they were taken into consideration. But the patients who were receiving GLP-1 drugs, agonist drugs, no, there was no such this for
No,
Why
them.
do you think?
So
Why do
is
GLP.
you think
that
that is? Why do you think that
That
is?
is that is you only answer that. That is what I also wanted to ask. Why do you think it is?
like, sir, because it requires optimization, sir. Like every surgical patient, we
See,
yes.
correct. Not only optimization, as soon as the patient comes in, if you are a genuine bariatric surgeon who does it according to protocol, you should never offer them surgery in the first go. So you should offer them proper diet, proper exercise. Still, they are not able to sustain, and then you optimize them with proper pre-surgical diet, and then you take them up for surgery. So at least that will require at least a minimum of 6 months of a trial. Sir,
Yes.
Yeah. See, other thing is, how will you optimize patients who are on GLP-1? You either give them the drug or you don't give them the drug. You can't optimize them
you
because
can tell them to do an exercise in addition to that to
you,
keep
yeah, yeah.
sustaining the weight loss as well as the sugar control.
Lifestyle
But you
changes
cannot
could
optimize
advise.
them.
Lifestyle, you can't, there is no need. See, for example, surgery you need to at least one is you need to know psychologically if the patients are actually willing to go ahead with the surgery and are they willing to do all the things necessary post operatively to sustain the weight loss. So you need time, and while you are using that time, you give them diet sheet, diet counseling, psychological counseling, exercise, and all of that. And in addition, for the 2 or 3 weeks before surgery, you ask them to go on a completely no or very low fat diet because you want the liver to become supple. Otherwise, the liver will be very heavy, and mobilization of when you operate, there potential for damage to the liver, injury to the liver is there. So all of these things put together, you need optimization for bariatric surgery. But to take medication, there is no need for optimization. You can start the medication and also advise all the lifestyle changes that we have already spoken about. Did you follow?
Yes, sir. Yes, sir.
Okay. Critique. Who else
Anna,
is
is
there?
anything else?
Tania.
That's all, sir.
Tania,
That's all.
critique. Anything more to add?
Nothing, sir. I was also thinking of the same points which were discussed.
Praveen,
Karthik.
Karthik,
Praveen,
yeah, Karthik.
Nothing much, sir. Whatever was there, everything was discussed, like what I have the doubts.
Praveen,
Subbu sir.
Yes,
What
sir,
I
that's all
feel,
true.
yeah, what I feel that the final sample, if you see that, there is quite a lot of difference between the surgical samples and GLP-1A 257. I don't know whether in a cohort study, okay, it may not be equal, but they should be a little more closer rather. I think this is a bit biased idea. That's what I understand because of the samples each one, like 1291 MBS, 257 GLP-1 RA. Um, Sorry, can you hear me?
yeah, yeah.
Yes, sir. Yes, sir.
Yeah. So what
So,
I
so,
feel
so,
that
sir, the thing is the GLP-1 this thing are a recent trend, and the surgery has been going on for ages. This thing, and I think for weight loss, GLP-1 receptors are a new thing now. So they were basically, so that's why probably they have the low numbers for GLP-1
no,
when compared to
I do
surgery.
agree. They may not get so many patients, but when you are doing a study,
Correct. I agree. Agree.
uh, this much of difference will it affect the result? I'm just thinking like whether it is. I think it
Yes, sir.
is a bit biased. That's what I understand towards.
Hello.
Hello, what do you say, Niranjan? I don't.
So that's what, sir. But the thing is, if the numbers would have been higher for GLP-1, then
Yeah,
probably would have argued that
Actually, I'm in a class.
the GL.
I'm in a class. I have responded to your queries. You please look at the WhatsApp. If there is anything, please call me tomorrow. Okay, thank you.
uh,
So I think but the bias for GLP-1 would have been more if they had higher numbers and surgery numbers would have been lesser. So it's the other way around.
yeah,
So
yeah.
Ravi Shankar sir.
Um, I didn't get the question. Sorry, because I got a phone call.
Ila, Subbu sir is telling since the GLP-1 numbers are less and the surgery numbers are more, so is there a bias for GLP-1? So I said it's the other way around because GLP-1 numbers are lesser
The
and
more
the
we
surgery numbers are higher.
Still,
So
yeah, yeah. If they were equal, the differences would have been starker. They,
stark, correct.
yeah, definitely more pronounced difference, both in terms of the cost and the weight loss and sustainability of the weight loss.
that's my
So I
point.
think, yeah, so that is why I think I don't think they have actually tried to, keep the numbers down, wantonly, but it has happened, as Niranjan said, because the GLP-1 agonists have been in vogue for diabetic control rather than weight loss, to achieve
Yeah,
weight loss.
yeah.
Okay, Sameer, go on.
Yes,
Tell
sir.
us what you think.
Sir, pros have been already discussed, sir,
Yeah,
and economic evaluation is a pro which I felt, sir.
yeah,
And
correct.
the main con, which I think is a coding bias, sir. Like, because they rely more on the EHR, like electronic health record data, and the pharmacy codes, also like the ICD codes. It may like over capture GLP-1 related adverse events, and it can like miss on minor surgical complications which are treated like on OP basis or something like that, sir.
See, here
So
you are not evaluating complications, no? You are only evaluating one, weight loss, two, cost. So
yes, sir,
it
but
doesn't matter. It doesn't matter.
the sir, but the patient will come to the hospital for the complications.
Complications, and then
Yes,
so the cost may be affected. Yeah,
yes,
you
sir,
are
yes,
right.
sir, yes,
That
sir.
way you may be right, but by and large, I think I think they are more rigid about all this hospitalization and the cost that they incur. So I don't think there will be so much of data loss as far as that is concerned, because insurance companies, even if they don't maintain patient health parameters, cost parameters, they will not miss. So I don't think you should worry about that.
Okay. And there was no quality of life, this thing, sir, in the uh,
See,
like
the
as
quality of life is a
yes, sir.
separate thing. So that
Yes.
you can't say that is. See, when you set out, I know I agree. These days, everything has to have quality of life assessment, so that is a given. But because they are only looking at two parameters, which is the cost and the weight loss. So quality of life, not being there is not does not necessarily become a negative point.
Okay, sir.
What do you mean by underreporting of what?
Sir, on underreporting of the after the metabolic surgery, the complications may, if at all, they are treated somewhere else, sir. So probably that was one thing, sir. If at all they're not
Oh,
captured,
Samir, but you said no, the insurance data they have taken. If they were treated anywhere else, the insurance would have shown.
that is what,
Uh,
sir. Some minor like complications would have treated, like they would have treated somewhere else, sir.
no, but wherever they treat, once I think that is how the insurance works in the West. So wherever they go, that insurance particular will be taken. I don't think they will pay cash if they go to somewhere else. Sir?
Yes. Okay.
Correct. So that is another one thing. And unlike here, where people have complications and go elsewhere because they think you have done something wrong, there that is not the case. There
Okay.
they are supposed to go back to their own people only. Very rarely do they, for example, if they were on a travel or something like that, they were in a different place and then complication happened, then they will access healthcare elsewhere, but ultimately they will come back to the original person. And as Niranjan said, everyone this data is entirely based on insurance claim people, not people who pay money for it. So all the data as far as the costing and things are concerned will be captured. Okay, carry on.
We have already discussed the sample size, and the study mainly there was this basis on a like based on a null hypothesis that there is no significant difference between metabolic surgery and the GLP-1 receptor agonist therapy in terms of mean total weight loss and ongoing healthcare cost, both medical and pharmacy healthcare utilization over a 2-year follow-up period. Uh, for the analysis, they have used for the continuous data, they have used Wilcoxon rank sum test, and for categorical data, they have used the Rao Scott second order test, and time related, they have used a linear mixed effects model. So, Wilcoxon rank sum test, it is a non-parametric test to compare two independent groups distribution when the data is highly skewed, such as in this study, which is weight, follow-up duration, medical, pharmacy cost, or the weight data, which is multiple times it has been calculated. And Rao Scott second order test for the it adjusts the standard chi-square test for complex survey sampling, such as in this study for variables such as insurance type, different comorbidities, medication category, and it maintains the um, categorical data. As of for the time related model, they have used a linear mixed effects model to base to dif, to balance the baseline difference since there is no randomization. They have used a propensity score, which is a statistical technique which is in observational studies to make treatment groups comparable so that it mimics a randomized control trial as closely as possible. So because this was a observational study, the two groups are not randomly assigned, and they have given propensity scores to remove the baseline difference, and they have used the generalized linear mixed models which distributed the um, missing data and the correct distributions across the different variables. Further, they have done a sensitivity analysis to obesity only subsets and sensitivity analysis repeats the analysis under alternative assumptions to ensure that the results are robust, restricting to obesity only patients, so that the findings are not to confirm that the findings are not only driven by diabetic related prescribing, to differentiate between diabetic related prescribing and obesity. They have done a sensitivity analysis.
Okay, let's ask Praveen. What is propensity score matching, man? Praveen?
Sir, yes, sir.
Huh. Are you there?
Uh, it's to estimate treatment effects, sir.
No, speak out loud. I can't hear you. Ainas?
So, it is mainly used in cases where, like in studies where randomization is not possible, sir. So, basically, to reduce confounding. So, you basically match in such a way that you're creating comparable groups based on the probability of them receiving the treatment, sir. So, if at all, the treatment groups are extensively differing, that is when you do this propensity score matching, sir.
Usually, when randomization is not possible, when randomization has not been done because it is a retrospective study. So, in that situation, if you are comparing patients who have, for example, have lot of other comorbidities and things like that, and where the cost would have gone up because of those comorbidities, for example excessive smoking. So you are comparing a person who smokes 50 cigarettes per day with a patient who is non-smoker, then obviously there are issues there. So to avoid this alpha 1 error, and as you said, selection bias, and you do what is called as propensity score matching. So you give a propensity score to each subject and then compare subjects with similar scores. So that way you avoid bias and confounding factors. So that is the essential of propensity score matching, used, as you said, in situations where randomization is not possible, which is usually rare, but in retrospective studies where randomization has not been done. Niranjan, anything to add?
Nothing, sir. Nothing, sir.
Subbu? Hello, Subbu, are you there?
Oh, yeah, nothing much to add. Of course, it is the same as you said. When you can't do a randomization, then you have to bring it to the propensity scores so that the bias is reduced.
Okay, carry on, Sameer. Sameer, are you hearing?
Yes, sir. Yes, sir.
Ah,
Yes. Sir, I'll first dive it into the flowchart. Um, so approximately 1,77,227 patients were filling GLP-1 receptor prescriptions or underwent MBS were initially enrolled, and then it finally 30,458 patients who had final claims based sample. This is the economic sample, and then 1,548 patients, which is the final sample with claims and the clinical data were included. As of for results, the patients who underwent bariatric surgery, they experienced a rapid and substantial decline in body weight soon after the index procedure, with weight remaining consistently low throughout the follow-up of mean of 33 months. In contrast, patients who were treated with GLP-1 receptor agonist demonstrated a more gradual and modest reduction in weight. And the graph over B shows the excess of ideal weight which was lost. Following the bariatric surgery, excess weight decreased dramatically, reflecting effective correlation of correction of severe obesity. While GLP-1 receptor therapy also reduced excess weight, but to a much lesser extent. The sustained divergence between the curves, which we can see over here, demonstrate that surgery is more effective. Then over the graph C, which is the weight loss, like from the starting weight, bariatric surgery resulted in an average total weight loss of 28% approximately, whereas GLP-1 receptor agonist achieved about 10% weight loss. And this emphasizes the superior efficacy of surgical intervention with the clinically meaningful sustained weight loss. And the graph D shows the excess weight loss. Almost about two-thirds of their excess weight was lost after the metabolic bariatric surgery, and only of a quarter, one quarter of a loss was seen in patients who were treated with GLP-1 receptor agonist. And this graph highlights the ability of surgery to normalize the body weight more effectively and their potent treatment. The second table over here, which shows the baseline cost. At, at baseline, the cost were almost similar between two groups. And in the first year, metabolic surgery group showed a sharp increase due to the surgical expense, whereas the GLP-1 receptor agonist showed a steady rise. By the second year, metabolic surgery cost dropped substantially below baseline, while GLP-1 receptor agonist cost remain elevated. And the pharmacy cost per month was more higher for GLP-1 receptor agonist, all which were statistically significant. Medical cost for bariatric surgery patients had a pronounced spike in the first year after the surgical procedure and for the perioperative care. After this, the medical cost became similar between the two groups. Over a total of like 2-year follow-up period, the total cost, pharmacy cost, and medical cost all were higher in GLP-1 receptor agonist and were statistically significant. For the weight loss between the two groups, bariatric surgery had a substantially greater total weight loss with a mean reduction of 28.3 of initial body weight comparing to 10.3 of GLP-1 receptor group. And there was a higher proportion of surgical patients who achieved sustained weight loss, which is 10% sustained weight loss. And mm, all these differences were significantly, like statistically significant, showing that bariatric surgery was more effective. For the comorbidity reduction and the healthcare utilization, patient with bariatric surgery group had a significantly lower healthcare utilization and fewer inpatient stays, outpatient visits, and also less ER visits per month compared to GLP-1 receptor agonist group. And the comorbidities at follow-up was less, including hypertension, hyperlipidemia, joint disease, depression, were significantly lower in metabolic surgery group, and which shows that bariatric surgery associated with improvement and prevention of obesity-related conditions.
Yes, Inaz.
Sir, first, the like they have used appropriate tests, taking into account which to be applied in continuous data and categorical data, sir. Then they've also, because randomization was not done, they have used the appropriate models to ensure that they can eliminate confounding as much as possible, sir. In terms of like in con, again, it's a retrospective study, sir. So like that is one con, sir. Like it is also, in terms of the analysis, it is portraying to be a con. And one more point, sir, that this in the GLP-1 group, the because it is an like the claim data which has been taken, they we actually don't know like the adherence to the drug, like whether the patient actually took the medication, what if they the duration of continuation, and especially in these drugs, like the dose needs to be escalated. So the effectiveness of this could be underestimated, sir. That is one con I
No,
thought.
how can it be a con,
Sir,
Ainas?
because
Because,
we
see,
don't
because
know.
all of the GLP-1 receptor agonists were all injectable. There was only one semaglutide tablet. Otherwise, everybody is injectable. So, are you going to tell me that people will buy it from the pharmacy and just keep it at house, keep it at their home and not take it?
No, sir. I mean, like if they have properly adhered to taking it regularly, sir, and like missed dosage or something along those lines, sir, or if the dose escalation was not done properly, like
Hmm.
I thought in that way, sir.
Yeah, that may be the case.
Anything else?
And that's all I could think of, sir.
Uh, so Likit is there? Likit,
No, sir, he left.
he left.
Yes, sir, maybe some
Okay.
call from emergency.
Praveen,
See, I tell you, all of you,
Uh,
because there are less number of people, unless it is a real critical call where you have to go and attend, suturing and things, it can wait. So don't leave the class for small things because you don't want to attend the class. But this applies to everybody. If it is something serious, because suturing, nothing will happen if a patient is not sutured in unless the patient is bleeding. So you need to be, I think, because the numbers are less, one or two people leaving the class, makes no sense to continue the class. Okay. Praveen, critique.
yes, sir, I had the same doubt about that other answer. And analysis, they have done good analysis, sir. Variant components they have searched in, and most of them are significant results.
Karthik.
anything else? No, nothing. Okay. Karthik,
Uh, Nothing I could think of, sir. Like whatever they discussed, it was the same thing. It was coming in the initially, but now I couldn't think anything else.
Sanya,
Sanya.
Same, sir. Nothing to add.
sir, Subbu sir.
No, no, I think it is fine because they have done a quite a good analysis. In fact, they have taken all the parameters properly. I don't
Okay.
think there is anything to say wrong or biased in this.
Okay. Sir, anything
Mistake.
to
I
add?
don't think, yeah, nothing to add.
Yeah.
Let us see what
Samir,
Samir.
Samir,
Yes, sir.
Yeah, what is your critique?
Yes,
Anything to
sir.
add?
So I think everything has been discussed, sir. Like the adjustment models, mimicking the randomization, and sensitivity. Sir, I have not added over here, but the sensitivity analysis which they have done shows that like they have excluded the only GLP-1 for diabetes versus obesity, sir. They have done that analysis also.
Hmm.
So it is also a pro, sir.
What are the cons of the
Limitations, sir.
study?
Like there was no subgroups for GLP, sir. There were even like older
Yeah,
drugs which were
correct.
used, but I mean they couldn't like the data was from 2018 to 2023, so I mean it could not be helped. But even older drugs were used, which had a less effect on weight loss as per se. And the cost difference or the inflation between from 2018 to 2023 was not they've not assessed it. the inflation of the things, sir. And it is based on a specific population, like subsets with the um, like the patient who are insured. So the I don't think we can um, how to say, sir, like we can't
Generalize, you mean?
yes, sir, generalize, sir.
No, but there is an if they just because they are on insurance, how does it actually make a difference? Insured patients are no different to anybody else. What about missing data? What you said about missing data?
um So same, I had that same thing, sir. Like because like GLP-1 agonist have a this gastrointestinal side effects, sir. So the oral drugs such as like semaglutide, uh, adherence they have not like we can't analyze, sir, in this study adherence to the drugs, sir.
Majority of them are not on semaglutide tablets.
Ye-
Majority of them are
Yes,
injectable ones only.
sir.
Only one group, one set is on semaglutide oral tablets. But I
And
think what is starkly evident is the more than the significant weight loss and also the reduction in cost. I think what the physicians, especially who treat endocrinologists who treat obesity and diabetologists who treat diabetes and obesity, have missed is that the end organ, is one a damage that actually there is, I think somehow the nobody is actually forthcoming to do this analysis where there is improvement in end organ damage, that is, for example, retinal damage, renal damage, vascular in terms of ischemic heart disease and cerebrovascular accidents and peripheral vascular disease, and all of these things, hypertension, all of these things, there is a significant reversal of the end organ damage with metabolic surgery, which is not seen with the GLP-1 agonists. And this point somehow doesn't get analyzed because the pharmaceutical industry will not want to do this, because that will then push more patients towards surgery. I think this point is not even told to the patients, that if you keep taking the tablets, your weight loss will not be as dramatic as metabolic surgery. If you keep taking the tablets, the reduction that you see is not sustainable compared to metabolic surgery. And if you keep taking the tablets, the cost will keep escalating as opposed to one time cost that you incur with metabolic surgery. So these 3 points they may say, but what they don't say is that there is reversibility and complete reduction in diabetes in a significant portion of patients, and also reversal of the end organ damage, and need for active intervention in terms of ischemic heart disease, peripheral vascular disease, joint replacements, and such like, is not highlighted at all. So I think if this again, this study brings it out, but it will not be highlighted. Niranjan?
Yes, sir. Agree, sir. Hello.
Carry on. Carry
Hmm.
on.
Okay, sir.
This
Samir.
Sir.
discussion.
Yes, sir. So, coming to the discussion, it is a one of a kind of study. Um, the study is a one of a kind because it is a first real world large scale head-to-head comparison between metabolic bariatric surgery and GLP-1 receptor agonist. Unlike the randomized trials that have evaluated only the medication, the study combines insurance claims, pharmacy data, and real world electronic health record measurements. And there is this study has a integrated approach and allows a particular population level comparison of costs, utilization, and clinical outcomes. It uniquely reflects the actual prescribing patterns at a real world healthcare spending rather than idealized trial conditions. So the study has provided insights that are highly relevant to healthcare system planning, the particular to the payers, clinicians in the current era of rapid GLP-1 adoption, which you are seeing now. And the study has shown that the weight loss, again, the findings reaffirm that bariatric surgery delivers more substantial and durable weight loss compared to GLP-1 therapy at the 24 months, which and also GLP-1 agents such as semaglutide and tirzepatide achieve strong short-term outcomes, and the real-world results are influenced by, again, variable adherence, drug discontinuation, difference in potency between the old and new agents, and insulin interruption. The study aligns with decades of literature showing that metabolic surgery remains the most durable weight loss intervention, even with the advent of powerful pharmacotherapy. The adverse effects, although the study has not directly measured complications in details, claims based data may underestimate minor surgical complications since outpatient or out of network events may not be captured in the data. However, the study has showed lower overall healthcare utilization in surgery group over the 2 years, suggesting that the long-term complications of metabolic surgery are limited. Post-operative metabolic improvements, like the from the GLP-1 receptor agonists, are high due to the discontinuation is high due to gastrointestinal side effects, intolerance at higher doses, and obviously cost-related non-adherence. In the long run, the study has shown the durability of surgery, which is long-term benefits, 5 to 10 years it is already well established. And the cost trajectory from bariatric surgery involves although it involves a one-time cost spike, but GLP-1 therapy leads to continuous rising pharmacy cost. And the study demands a longer horizon study where more like 5 to 10 year data, which the authors have argued that the future work should evaluate 5 to 10 year cost trajectories, cardiovascular outcomes, and long-term medication adherence and quality of life measures to be done in the future run.
See, I think you
Sir.
can make this a competition, or at least if the insurance companies are smart, they will really look at this data with the hawk's eye and realize that the pharmaceutical companies are taking them for a ride. So they have to, advocate that the bariatric surgery should be the main procedure of choice and not this one, the GLP-1 agonist, because if you look at it, one, in terms of weight loss, see, other thing that you have to realize is all these agonists are only there in the market for 3 4 5 years maximum, but the metabolic surgery has been there since 1976 when Scopinaro did the Roux-en-Y gastric bypass, though at that time he did it in open surgery. Subsequently, it has become laparoscopic. So we have data from 1978 or 76. So 24 plus nearly 50 years of data in terms of the metabolic surgery, the associated problems and things like that, which is hardly anything. If the patient survives the surgery, they will generally do very well. Very little complications post surgery. On the other hand, we don't know what are the medium term, long term side effects of these drugs. Third thing is we don't know the cost, the cost escalation that keeps happening. And I feel the most important thing that needs to be stressed is, as of now, there is no data which suggests that GLP-1 agonists will reduce any of the complications. It may reduce the weight, it may reduce the sugars, but reduction in complications, reduction in end organ damage is not shown by any of the studies. So if the insurance companies are smart, they will pick up on this. But unfortunately, I don't know whether the pharmaceutical industry is more powerful than the insurance industry, I suppose. Niranjan, when it comes to
Sir, that is what
conclusion.
I think. Samir, do you have still more slides regarding literature review? Sameer,
Sameer, do you have any
Yes,
collateral
sir, it is
reading?
there, sir. Collateral studies there, sir.
and then we will conclude later. Then
Okay,
finish
sir.
it off.
Go
Collateral
to the
studies.
Yes,
Yeah.
collateral studies.
yes, sir, yes. Okay. So this was a study of Northwestern School of Medicine, which was a 2-year
Too
retrospective.
crowded. We cannot see anything. Okay, you explain.
Yes, 2-year retrospective data, which again evaluated the cost effectiveness of bariatric surgery versus GLP-1 receptor agonist. It again found that bariatric surgery, either sleeve gastrectomy or Roux-en-Y gastric bypass, provided a greater health benefit at lower long-term cost compared to GLP-1 medication alone, which are not cost effective at current prices due to the need for prolonged use and higher cost annually, almost 11,628 USD annually, and while they found that the bariatric surgery is 18,581 US dollars once. And there is also a study from American Society of Metabolic and Bariatric Surgery, which compared the effectiveness of semaglutide and tirzepatide versus bariatric surgery. This was again a 2-year data, which had shown that surgical patients had lost almost 24% of the body weight, about 5 times more than the one who have been prescribed the GLP-1 medication. And GLP-1 users, even they had a therapy for 1 more year, the weight loss was almost around 7% only, which was much lower than the surgery. Before uh, we conclude, sir, I will just touch upon the Indian scenario. The semaglutide, which is Ozempic, that is the only one which is actually available in India and approved only for diabetes, but it is widely used off-label for weight loss. Liraglutide, which is Saxenda, which has a limited ability and it is mostly imported from outside, and it has been approved for obesity, but it is expensive. And then we have the Monjaro or Zepbound, which is not officially launched and only via import channels. It is there. Insurance coverage is almost universally not covered for obesity. The duration which needed is again, which we have discussed, is long term, that is lifelong in many patients to prevent weight regain. In India, the cost monthly will be around 45 to 60 K, and a financial burden of around 3.6 to 6.4 lakhs per year, which is again lifelong. Most patients in India, they cannot sustain therapy beyond 6 to 12 months, mostly due to slower or capped doses to reduce expenses. Weight regain after the discontinuation is very common. Use is again restricted to urban upper middle class patients only. And then again we have the all the drugs are injectable. No Indian generic has been yet to be done. And in India, obesity is still considered a lifestyle condition, and so it is not reimbursable. Imported drugs, again, they carry customs cost and the cold chain, which has to be done. Um, in future run, entry of oral semaglutide and Indian biosimilars may probably reduce the cost, and tirzepatide launch in India is still to be done.
No. Sameer, that is wrong.
Yeah.
Terzepatide is launched by Eli Lilly in March 2025. It's available now. Okay,
Yes,
so the
but
cost vary between anywhere between if you want the obesity dose, it varies anywhere between 20 to
uh,
25K per month.
yes, sir.
So that it is available now.
Yes.
The thing is, the compared to Ozempic, this is more effective. But again, the side effects of both the drugs, sustainability long term, as well as the weight regain once you stop the treatment is the key thing. And
Yes.
one more major thing is all the drugs which are available in India or anywhere in the world are all diabetic dosages. So if you
Yes.
want to give a obesity dosages, the cost again will go up.
Sir, but I had one question, sir. Like, if,
Hmm.
Insurance inclusion, it's still not there in India.
Insurance inclusion for bariatric surgery is there now. The IRDA has clearly given a guideline which has to be followed by all insurances now. Although the acceptability of from the insurances have drastically improved, but there are strict guidelines. It has to be minimum of 3 years of prior insurance, which the patient should have taken, and then it should be a new onset obesity. If it is congenital, they won't give. So if the 3 years insurance is there for the past 3 years and patient has new onset obesity, according to the WHO or the Asian bariatric this thing guideline, if they come under that particular criteria of the category of BMI with comorbidities, the insurances are giving. I don't think they are yet to give the reimbursement for the GLP-1
Yes, sir.
agonist. That is not there, but for
Yes, sir.
surgery, it is definitely
For
there.
surgery, it is there, sir. For GLP-1, I was saying the Indian scenarios.
Yeah, GLP-1, it is not there.
Yes, sir. Uh,
Sir?
Yeah, I agree. Correct.
Samir.
yes, sir.
So,
Again, the question, sir.
hmm.
We consider early metabolic.
Anas,
What is the answer, Ainas?
Yes, sir. Like we'll prefer bariatric surgery over GLP-1, sir. For weight loss management, sir.
Why are we
Because of
losing the battle to the medication?
sir, because we don't have proper data, sir. Then and like it was mentioned, sir, we
There is
don't
enough data.
GLP. Uh,
There is
so
enough data.
yes, sir. And sir, the point that you mentioned that GLP-1, the medication is showing glycemic control and it is showing weight reduction, but it is not impacting the complications firstly. And
no, now
the
WHO current recommendation in December 2025, they say the cardiac risk factors are definitely reduced with GLP-1 agonists. The risk of the person having cardiac diseases like MI and all those are definitely reduced with GLP-1 agonists. That is there.
is,
Apart from that, rest of it is still under study. See, the main thing even before that, it's like comparing apples and oranges. So, if that GLP-1 agonist would have induced at least a similar weight loss or little lesser, it would have been acceptable. So whatever the studies they have shown, maximum weight loss probably is around 15% to probably 20%, which they claim excess weight loss, which I'm talking about, versus surgery excess weight loss, even with sleeve, is around 65 to 70%, or at least 60%, 50 to 60%. So there is a drastic difference between the induced weight loss with GLP-1 and surgery. And major thing is GLP-1 agonist weight loss is like if you have to sustain, you have to keep on giving the drug. And whereas in bariatric surgery, once it is done, it is done. 10% of patients might regain certain amount of weight, but you again have other options. So the comparison between the two is definitely not there in the current scenario until and unless some drug comes which matches the amount of excess weight loss. So you cannot compare the two and say that this is better, the GLP-1 agonist is better or comparable to the surgical management of obesity. Sir?
yes,
Correct. But so my I think apart from the cost difference, as you see, one time cost of maybe 3 to 6 lakhs for a bariatric surgery, and in higher centers maybe it's a bit more compared to sustained the cost of about, let us say, on an average 30 to 40,000, which will cost anywhere between 3 to 5 lakhs per year. So if I think your surgery will pay up, yeah, the cost of the medication in 1 year only. So after that,
Correct.
everything that is a bonus. On the other hand, you have to keep taking the thing. And I think the other thing is, there are already a lot of alarming side effects that are coming up, may not yet been proven, but sustained over a period of 5 years or so, many of these questions can be answered. and see if there is any.
Sir, many of these patients they can't even sustain for a month.
Yeah,
So they get loose motion, GI disturbances, bloating because
correct.
of low motility. So until and unless we get those newer generation of like Monjaro or something which are more effective and probably lesser side effects. Nowadays there is a trial going on for the what is I forgot the thing which has a triple benefit.
Ricatrate,
So,
one Rica.
Ricatride, yeah,
Yes,
Ricatride.
yes.
So that is showing promising results. So till such a drug comes, I don't think it is effective in patients who have like morbid obesity. Probably in a select set of patients who are overweight, who neither fall into the category of normal weight nor they fall into the category of morbid obesity, where surgery is the recommendation. So, in those select group of patients who can tolerate and probably who can afford this, it definitely, in that particular scenario, probably it will be effective. As of now, that is what my observation is. Sir,
Correct. Correct.
Subbu sir, any comments? Final comments?
Yeah, in UK, actually, they wanted to keep only the surgery as an option. But what is happening is the wait list is so bad. I think up to 50 years or something like that. There are too many obese people there. So they started giving Ozempic now. Very recently, they have started tirzepatide. That is actually accepted by the NHS, but it's quite recent. I don't know whether they are easily available for the NHS patients in the pharmacy. So
Yeah,
it
I don't. I think it will be a huge burden for NHS if
and it
they
will be very difficult for
openly,
them to
yeah.
manage. Now they are in a difficult position whether to give surgery, which is a long, long wait list, and at the same time, if they want to give the tablets, it's also a burden. They are in a difficult position now.
And also, I don't know whether it is influenced by the pharma industry. The recent WHO guideline has included GLP-1 agonists as a treatment plan for patients with obesity
Obesity, yeah, yeah.
and diabetes.
But I have seen those who have had these treatments are mainly they have got it done outside NHS because they
Hmm.
can't wait for so long or for anything, either GLP-1 RA or even the surgery. So it's difficult to say how far it is okay because everything is new even there also.
Anybody else? Any comments, Sanya? Karthik? Final comments. And Samir's
Nothing.
presentation.
Presentation was good, sir. In detail, even discussion was really nice.
Karthik?
It was a very interesting topic, sir, to understand how the
Hmm.
bariatric surgery and the GLP-1, like understanding both is very important in the future management. In that way, it helped a lot.
Sir, final comments?
I think, Samir, I have to congratulate you. You understood the subject well, and you covered it in a very, extensive manner with the, explaining in the background and also the statistical tests and everything. It's a very balanced and very, I think quite, I would say, mature presentation of the subject. I think it, and you didn't just speak from the slide; you were able to vocalize well. So all those things are extremely good. Now, not much to say negatively. So there are no cons. So well done. Keep it up. Keep improving.
Yes, thank you.
The topic, I
Yes, sir.
think we have already come to a this one. There is no doubt that I think metabolic surgery is much better. But somehow, I think we have to, as surgeons, we have to market ourselves better compared to the pharma industry. But we are taking a huge, giant. I think pharma industry is, one of the most powerful, thing in the whole world. So, it's quite tough to take them on. But I think we have to, if we get this one with insurance companies, we can tell them. If they agree with us, then I think then we can actually make those two fight, and maybe that will the fight will come in favor of bariatric surgery.
Yes, sir. I think Samir presented well. I agree with sir's comments. If there are no more doubts or comments, I think we will conclude.
Yeah. Good night.
Thank you, sir. Thank you. Thank you, everyone. Thank you, Subbu sir.
Thank you.
Thank you, sir.